Mesdames, Messieurs,
Ladies and gentlemen,
après l'étape de ronde de ce
after
matin,
the roundtables
vous
of
avez un
this
défi.
morning, you have a challenge,
Un peu plus de 50 minutes. Répondre à
some
cette
50
question,
minutes to
Sécu,
answer this question.
quel avenir pour cette
Social
vieille dame de
Security,
80 ans?
what is the future
Alors,
for this
soins
80-year-old
intensifs,
institution?
EHPAD,
So,
soins palliatifs,
what will
on
it
va
be?
voir.
Care,
Mais en tout cas,
palliative care, etc.
décès, voilà. Non, plus sérieusement,
More seriously,
on a entendu depuis 2 jours
we
un
already
certain
for
nombre
two
d'éléments
days we've
diagnostiques.
heard
On a entendu
different
des débats,
diagnostic
des
elements, we've
accords, des
heard
désaccords, des
debates,
propositions.
agreements, disagreements,
Il nous
proposals.
revient la lourde tâche
Now we
d'essayer une
have
synthèse,
this
45 minutes.
heavy
Je
task
vais
in some
commencer par
40,
M.
50
Yann-Gaël. M.
minutes
Yann-Gaël est
to take up
président
this
du Haut
challenge.
Comité
We have the
pour
president
l'avenir
of
de
the
l'assurance
High
maladie,
Council for the
une
Future of Health
agence
Insurance, Yann-Gaël, AMGHAR,
d'État qui
this
est censée
state
réfléchir et est là
agency
pour réfléchir à
which
ça.
is to think
Vous
about
avez
these
émis un
kinds of
rapport sur
questions.
ces questions.
And you have a
Essayez,
report
dans un
on
premier temps, on va
this
faire un premier
topic.
tour de
First of
table
all, we're going
de
to
cette
go
manière, et puis
around the
ensuite vous
table
échangerez.
and then we'll be
Dites-nous comment
exchanging.
vous
But
voyez,
we do say,
alors
how do you
en vous dégageant
see
un peu du quotidien
now,
et du financement, du
going a
PLFSS et
little
du
bit
mouvement 6, bien sûr,
outside of the
comment vous voyez
daily
l'avenir de la
work, how do
Sécu,
you
ce système
see the future
formidable auquel nous sommes
of
tous
this
attachés?
fantastic social
Alors,
security
la
system
première
that we're all
chose,
attached to?
avant de
The
venir à
first
cette limite, c'est
point,
qu'il faut déjà éviter le faux
for having a
diagnostic.
treatment, we have to
Or,
avoid a
le sujet,
false
ce n'est
diagnostic.
pas
It
seulement,
is
c'est même pas
not,
principalement, pas d'abord
and not first of
comment on
all,
finance l'assurance maladie, mais
how
c'est
do
comment on
we
finance la
finance Social
dépense de
Security?
santé,
How do we finance
qu'elle
health
soit financée par l'assurance
expenditures
maladie, par les complémentaires, par le patient.
by the
À la fin,
different
ce qui compte, c'est l'effort
complementary
que la
or the
nation,
obligatory
par différents
health
canaux,
insurance? And we
dépense pour
have
sa
different
santé.
channels
Et ça, c'est comme toujours important
related
de bien
to health
dissocier les deux.
expenditures. We need
Parce que
to
pour le
really
coup, ce
dissociate
qui aujourd'hui
these
fait débat, c'est
topics,
notre
these issues,
dépense santé.
because our health
Déplacer la
expenditures
contrainte
is the
depuis
debate.
l'assurance
Now,
maladie
if we
vers le
take
patient
the
ou vers un
constraint
complémentaire ne
from
change
the
rien
health insurance
à
to the patient,
l'effort global
doesn't
que la nation devra
change
y mettre.
the
On
global
a même une
effort
expérience
required.
naturelle
In
de
fact, we
grande
have a
ampleur qui se
natural
passe aux États-Unis qui montre
experience
que
from the
désocialiser
US.
et
We have
déréguler
to
ne réduit pas
dissocialize
la
and
dépense, bien
regulations
au
does
contraire.
not
Je le dis
avoid
ce matin et je le reconnais.
expenditures.
Et
On the
c'est pour ça que quand
contrary,
j'entendais
so
hier
when,
un
in
intervenant
fact, I
dire
heard
qu'il faut
yesterday
revoir notre modèle
that we need
social
to
sur les
review
retraites
our
et sur la
social
santé,
model, we
c'est
have
une
to
nature
look at the
totalement différente.
retirements.
Quand si on réduit la
This
dépense
is
publique de
different
retraite,
to
on réduit
reduce
globalement l'effort de la nation pour
expenditures,
les
and
retraites.
we
Si on
also
réduit la
be
dépense publique
reducing
de
the
santé,
efforts
on ne va pas du tout
of the
réduire
nation.
la
If
dépense de santé, on va
we
juste
have to think of
organiser différemment
how
sa
we
répartition.
can
Donc les
organize
dépenses de santé en
differently.
France,
Now,
elles
health
augmentent pour des raisons
expenditures
bien
today
connues,
are increasing for well-known
mais elles ne
reasons,
dérapent pas non
but
plus.
it
Si on regarde la
is
consommation
not
de soins et d'aide
really off
médicaux entre
track,
2010 et
because if we
2023,
look from
elle n'a pas
in just
rapporté au
recent
PIB.
years,
Ça n'a pas augmenté, ça
and
a
we
suivi
look at
la
the
croissance de
percentage of
l'économie.
GDP,
Si on prend
it
les
is
dépenses courantes de
following also
santé,
economic
sur la même
issues.
période, elle a augmenté
Now,
de
for the same
0,7 points de
period,
PIB. C'est significatif.
0.7%
C'est
of
moins
GDP.
que nos voisins allemands
It's
ou
significant, but it's
britanniques
less
qu'on
than
prend
our
souvent
German
comme exemple
and
de pays
British
vertueux en
neighbors,
matière
who also
de finances publiques
look at
ou de
us
maîtrise de leurs
and
dépenses de
for
santé.
our
Donc
management
déjà, je pense
of
qu'il
the
faut quand même
health
se
system. I
positionner
believe
peut-être pour un
it's
diagnostic
important
qui,
to
effectivement,
look
doit
at
prendre
these
en charge une
positions.
augmentation
We
des dépenses de
need
santé
to
du fait de la démographie,
really
de l'épidémiologie,
cover
des nouvelles technologies,
the
mais il n'est
different
pas nécessairement
increases in health
catastrophique. Ce
expenses
qui
because of
impose
these different
une action,
factors
c'est
today.
qu'on a
But
d'une part
what
une marge
we
d'efficience comme
have,
dans tout
first of
système,
all, we have
et que
the
par ailleurs, on a effectivement une situation
system
de
we need to look
déficit
at.
de
We have
l'assurance
the
maladie qui
uh,
peut,
health
et là c'est
insurance
l'ancien trésorier de la
deficit
Sécu qui parle,
issues,
très
and
vite
we
créer
have
un risque
this can
pour le
create a
financement et pour la
risk for
continuité
the
du financement des prestations.
continuation of the funding
On
of
a
our different
chiffré
health
que
services.
si on
We
veut
have
ramener
quantified this. If we
l'assurance
want
maladie à
to
l'équilibre dans les années
have
2029, il
health
faut faire un effort de 300 milliards
illness insurance to be at a balance,
sur 4
will
ans.
require a big
Alors, les
effort.
leviers, ils sont pour la
Now, the
plupart quand même
different
très connus
levers
depuis très
are well
longtemps, ont
known
été
for a long
débattus
time
dans
now. They've been
d'innombrables littératures
debated,
communes.
Mais on ne sait pas les mettre en œuvre quand même.
Voilà,
but we
alors,
don't know how to
tout à l'heure,
implement them,
parce que voilà, on
says
parle
the
de gradation des
moderator.
soins,
We
on parle
talk
de
about different
pertinence, on
factors. We
parle
talk about
d'efficience,
relevance,
on
for
parle
example,
d'adéquation de l'offre aux
efficiency,
besoins de
the
santé.
different
Ce que je veux dire, la
offer,
première chose,
if
c'est
it's
qu'il serait
adequate.
illusoire de
And
croire que
it
ces
would
leviers
be an
d'efficience
illusion to think that
sont
deficient
sympathiques et
levers
indolores.
are
Et je rejoins notamment
really
ce que dit tout à l'heure
without
Pato.
pain,
La pertinence, on en
because
parle, mais si on
relevance,
veut
we will
vraiment en
talk
faire
about that. But if
plus,
we really
ça
want
veut
to
dire
do
qu'il faut
more,
admettre
this
un certain nombre de
means
curseurs
that
dans notre
we
système.
have to
Et
really
évidemment, il est
look
tout à fait
carefully at our
illusoire
ecosystem
de
and how
croire
we can better
que la
management,
seule
have better management.
vertu
And
des
the
comportements des
only
prescripteurs ou des
virtue
patients
of the
va
patients
compenser le fait
and the
qu'aujourd'hui, on a un
prescriptors
système
that
qui est
will
très
not be
permissif
actually,
Nous, notamment,
um,
quand on se compare à nos
in this
voisins
system, we're in this
musulmans,
ecosystem where
très
with
peu
we are
de justification
permissiveness,
prescripteur.
we don't require
On voit
much
que quand on commence à
justification of the
introduire
prescriptors.
des
When we're
éléments de
starting to
demande,
having the
de prescription à des
justification,
assurances maladie ou même un traitement,
prescription, these
le diabète étant un des
issues,
risques
for
médicaux
example, the
importants, on voit que ça crée une
diabetes
réticence. Donc,
treatment,
si à un moment on commence à la
then
pertinence,
we
c'est
can
ça que ça veut dire. Voilà.
On ne demande
make
pas de
changes. So
précisément
we look
beaucoup
at relevance. So our
d'obligations, enfin,
citizens
d'observance
don't
non
have
plus. Hein.
much
Ouais,
obligations,
ça, c'est un autre
don't have
sujet.
any. Well,
Mais
this
voilà,
is
je pense
a little bit different
peut-être que c'est
in this
l'idée-là
for
de
this subject, but
déficience
that
où
this
il ne
is
serait
a
pas facile des
lever
sujets autour, par exemple,
of
du
this
juste prix.
deficiency. For example,
Ouais,
the
ça veut
fair
dire qu'à un moment,
price,
ce
these
sont
kinds
aussi
of
des marges
issues
d'efficience du
are
système,
not
et ce sont des
easy.
marges qui ne feront pas plaisir à
And so
certains
these are
acteurs.
these margins
D'autre
also
part,
don't
la
please
grande
different
illusion à
sectors.
éviter, c'est de croire que la
Another
simple
the
efficience d'un
point we need to
système
avoid
suffit
is that
à
just
combler l'écart.
if
Dire
we
en
just
gros,
have a more
là nous sommes
efficient
aujourd'hui en
system,
2029, c'est 35
does
milliards
not mean we can
d'efforts.
just have a balance
La Cour des comptes a fait
that is
un
restored.
rapport au printemps qui est
The
très très
audits
volontariste, on peut le dire,
uh,
mais
court
l'effort d'efficience que la
has
Cour des comptes arrive à
spoken about
documenter
this,
dans ce rapport
and
d'avril, c'est
they
à peu près la moitié du
looked
chemin.
in April.
Ça veut
They
dire que la moitié du
made a
chemin,
progress, but just
l'autre moitié, il faudra le
halfway
faire
there.
par d'autres mesures.
The other
Et les
part,
mesures,
the
c'est
other
quoi?
half, we have to have other measures.
Concrètement, une fois qu'on a montré
What
les mesures
are
d'efficience, il reste deux
these?
choses.
Well, there are
C'est
2
soit
points,
réduire le
either
périmètre de prise en
to
charge,
reduce
mais il
the
faut avoir en tête
different
que vu les montants dont on parle,
charge
on parle de
amounts, the
15
amounts that we're
milliards,
talking about,
le périmètre de prise en
15
charge, ce n'est plus
billion.
des mesures
And
paramétriques, ce n'est plus
so
des petits
we
réglages
not there's
qui font
not
pas
just
plaisir, mais qui
small
changent pas le
minor
système, c'est que
adjustments
15
that
milliards
don't
ou
change the
même
system, but
la
the
moitié de 15
15
milliards de
billion or
changement de
even half
périmètre
of
entre
that
l'assurance
and the
maladie et
change of
pour
the
les patients,
parameters
c'est un changement
in
profond
this
du système.
area
On avait
is
fait
a
l'exercice
change in the system.
d'estime
We've
de se
done
dire
these kinds of
si on
exercises.
transférait
If we
7
want
8
to
milliards
transfer
d'un
7,
contrepartie
8
envers le patient, ça veut dire
billion
qu'on
to the
quadruple
complementary
les
health
franchisés de
insurance,
plafond.
then
Donc ça veut dire
we
que
will
la
have this
plupart des patients
disruption.
ne sont plus pris
So
en charge.
La
so
réforme des plateformes,
because
d'ailleurs,
then
vous
there will
expliquez tout à l'heure
be
quels sont les
the
effets.
patients will be
Si
paying
on fait la même
more
chose en termes de
for
transfert
the
obligatoire, c'est
remaining
15%
amount.
qui est modérateur. Ça veut dire que
So
la plupart sont couverts, ne sont plus
most of
majoritairement sur
them
l'assurance maladie. Donc voilà, pour cette
have to
ampleur
take up these issues. For
du
this
transfert de
extent,
charges,
the
c'est un
transfer
changement de système, c'est pas du
of the
paramétrique.
charges
Le
is
dernier
a
levier qui
change in the
reste, effectivement,
system.
c'est le niveau
And of
des
course, we
ressources
have the
accordées à
level
l'assurance maladie, donc c'est le
of
niveau de
resources
recettes.
for
Et je pense que ça a été
this
rappelé
health
par plusieurs acteurs
sector.
ce matin.
And
On
we've
ne peut pas
heard about this
imaginer
actor.
qu'on
We
fait ce
cannot just
chemin
imagine
sans
we
poser la
take
question
this
des recettes.
pathway
Très bien.
without looking
Merci pour
at
ce
the
premier
different
exposé. Vous situez le débat.
revenue
Philippe Juvin,
issues.
vous êtes membre de
Thank
la
you
commission
for this
des
first
finances de
measure.
l'Assemblée
And
nationale.
Philippe, you are a member
Vous
of
avez donc une vision
Parliament for
globale
the Finance, General
de
Economy,
l'ensemble des finances
Budgetary
publiques
Control. And so you have this
et au
global
sein de ces
vision
publics des déficits sociaux.
and
Au fond,
all these
cette
different
sécurité sociale à
social
laquelle nous
economic
sommes
issues.
si attachés,
So what we are very attached
elle
to our
peut
social
survivre.
security system.
Est-ce
Can
que
it
la vieille
survive
dame,
though?
quelles sont les
Now,
conditions
can
pour que la
this
vieille dame
old
continue à marcher, faire
institution
l'exercice et vivre?
can
C'est ça la question.
continue to
D'abord,
survive? This is really an important
en fait,
question.
toutes les solutions ont été
All of
abordées
the
depuis
different
48 heures.
solutions that we've
Mais
heard
je veux
already
d'abord rappeler premièrement que la vieille
since
dame,
the beginning
elle
of
continuera
CHAM,
à bien
the
faire son
institution
travail
will
si les
continue to do
finances
its work
publiques en général,
if
et je ne parle pas du
public
budget de la Sécu,
fund, and I'm not
les
just
finances
talking
publiques en
about the
général fonctionnent.
security budget,
Aujourd'hui, la
but if we have
situation n'est pas
public
là, elle est très
finance
grave. La France
continues, the
emprunte
situation
à
is
des
in a
taux
difficult
plus
situation.
élevés
We
désormais
have
que l'Italie,
high
voire sur
loans, higher than
certains
in
leviers sur la
Italy,
Grèce. Ce qui
that
montre bien que la
higher
signature
lending,
du pays
so that and
pose
even higher
problème. Mais il y a
than
même
with
des sociétés
Greece.
françaises
So
qui
we also
empruntent à
have
des taux
French
plus bas que
companies
l'État
that
lui-même. C'est la
are
première fois dans
actually
l'histoire. Donc on a une situation
borrowing money
extraordinaire
at lower
qui
levels than the
conditionne,
state.
savez,
So all of this
finances
conditions
publiques
the situation,
en
public
déshérence égale sécurité sociale qui ne
situation
fonctionne plus. Il faut bien
is
le comprendre, c'est un
connected
tout.
with the Social Security, which
C'est quoi
is
les
not
solutions?
working well. What are the
Dépenser moins,
solutions?
dépenser mieux,
Spend
travailler
less,
plus,
spend better, work
simplifier,
more,
débureaucratiser. Ça,
simplify
c'est pour les
bureaucratic
finances publiques. Et
administration,
certains de ces
and
éléments, de ces systèmes,
all
sont
of these
évidemment à développer en
systems
matière de santé.
need to be
Sur le
developed
travailler plus, la
further.
France est
Now,
le
to
pays de
work
l'Union
more,
européenne. Quand vous prenez
here
la
in
somme
France,
d'heures
when you
travaillées
look
par
at
an en
all the
France, vous
different
le
EU
divisez par le nombre de
countries
Français en
and you
bonne santé.
divide the
Et vous
number
aurez
of
la même
French
chose.
people that in
Si
the
on
working
avait le taux
population,
d'emploi
then
en
you
pratique
compare.
des
Now,
Pays-Bas, par
if
exemple,
we, for
c'est
example, if we
120 à
have the
130 milliards de recettes
employment
fiscales en plus
rate
chaque
like
année.
in
Vous voyez ce qu'on
the
peut faire.
Netherlands,
Donc il y a un
then
sujet
you
qui est
can see
systémique.
what we could do. We have
Deuxièmement, la
this
vieille
kind
dame,
of
si elle veut continuer à
situation. Now,
fonctionner,
this
il faut qu'elle ait une
old
vision
institution
supérieure
it
à un an.
continues. It needs to have
C'est la question de la
a
congruence
vision of
d'égalité avec
higher
la
than
société économique dont on
more
va parler
than
tout au long
1
de
year.
tout
We're
à l'heure.
talking
Ce
about
que je comprends,
this
parce
in the
qu'aujourd'hui, c'est
reality. topic that we just spoke about in the other discussion. So how we need to have a longer term vision of the revenue. We also have to relativize concerning efficiency issues, because if we look at, for example, a pluriannual in national defense, for example, even in the area of defense, when you look at the pluriannual laws, at the end of the execution, you have about the equivalent of one budgetary year. So you have to have this longer term vision, more than 1 year. You have to spend less money, spend better in the area of health. Now, maybe we have too many hospitals in hospital. Do we always have to see a doctor, first of all? Maybe we can just see with a nurse first, or maybe we can see the different therapists, physical therapists first. We need to be more open towards our health pathway to spend better, not just prevention, but breast cancer. So it's about some 4 billion expenses, so 30%, even as complicated to calculate, just as with the metastasis. So I think for the breast cancer, they have this metastasis. So we have these overrepresentation of serious illnesses, and to diagnose early on is very important. It gives us savings. It's very complicated to do them. Do you know the Minority Report? There was a Mission Impossible, this impossible mission. Tom Cruise, yes. In this movie, in fact, the theme is they have this thing that enables us to say, you will be committing a crime in X amount of time, and then we will stop you before you commit the crime. Well, look, we know today how we can forecast different, and we can predict very early on illnesses. So the hospital where I work at Pompidou, they have some data published, which gives basis on the health insurance data for 2 years to say we can identify 25% of people that will have a sudden death this year. I can say you. I can say that you will. What will happen? So you go to you will have screening. You will see the cardiologist. I'm not saying you when I was pointing my finger, but prevention, which consists of seeing a doctor who says, you have to eat better, do physical exercise. Of course, that's important. Stop smoking, yes, but that's not enough. We have tools available now. This is the old institution, which has to have transparency and quality. Now we have some simple indicators, not many indicators, because I do know how I can operate you, but I can do surgeries, but I know where you should not have a surgery. But I know this information where you should have your surgery done. Look, for example, if you have different injuries, if we operate you 48 after you've fallen, there were more mobility, mortality. If you ask all the different hospital establishments, the time period for surgeries. Well, if you can know this information, those who are waiting said, well, waiting in line, they know how we can accelerate for certain cases. So we need confidence. We need to have a win-win relationship. When you explain this, there is not acceptance for this amongst professionals, and there are winners and losers. And this is complicated to handle this. I don't agree with you. I think transparency for results is a tool to improve quality. It doesn't take much. It's very powerful. And it's a demographic challenge, because I know exactly where one should have their surgery done. So we have this institution is an open world. Ask the question of Mr. Trump's effects, consequences on drugs, and even on private hospitalization. His effect. I'm for the European market, free circulation of people, capital, etc. I'm for the unique EU prices. Of course, the states then can also have any deductions they desire. But this institution is an old one, but it needs to do more to really take care of those people who work for this institution. I'm a doctor already for 30 years. I was never asked if I read publications, if I actually drink. They gave me the keys of the Airbus to steer that. And for 30 years, they say I can continue to be the pilot behind this and steering this. In our hospitals, it's the same for all the different public services. We don't have a HR management. In fact, what the HR does, they just do they actually do the payments of the staff. But we do. We're talking about artificial intelligence, and we're talking and I also we have an amendment for this PLFSS where we can use digitalization, that each one of us can ask to have a consultation of this digital data. I will go back. If we don't have the staff to do this in the different nursing homes, things will not work. We today have to really take care of our staff. This is a major subject. This old institution, and I'm going to conclude on that, if we're going to continue to have Social Security functioning, it has to really respond to the definition of this prosperous society that we've heard in about Nina, Pivot, Raymond Arnon. What is your definition of liberalization? What he said was prosperous, and these are societies where we let the potentiality of individuals to be freely expressed. I believe in that. Give the doctors this freedom, give this freedom to the researchers, and they will find things that are not in tenders, and give the freedom to the industrialists. Stop all of this administrative burdens. Give freedom to the elected officials so that they will manage better hospitals. Freedom is very important. That's a project in itself. You spoke about HR, and this is the transition that Madame Cabanal, with the National Secretary of the CFDT, and also financing of Social Security. Now, this Social Security was financed by, as we know, by the staff, and different for demographic reasons. The situation is changing. The social partners still have a role, but they don't have the role that they had at the beginning. How do you position yourself concerning these questions about the future of the Social Security? You represent the staff, and we also have, in fact, what I want to say, what are the roles of the social partners in steering, in the governance of this Social Security institution, which is intergenerational and covers all the different staff? First of all, if I can react to what I've just heard, I always hear about this old institution. Okay, I'm tired of hearing that, because 80 years of age is not old, it's not the end of life. I would give this youth input here, but not only. We have the question, in fact, I heard the previous roundtable talking about competence. Social Security is one of the pillars of our social model. We talk about the right budget. We provide doubts of having survival. The death of a model are different predictions. So we have the collective investment is important. Now, are we capable today to have the right policies to say how we can have the best social protection? And we believe it's really essential to have social protection. It's shared, but we don't talk enough about this. A social model is not just a promise that we did 80 years ago, we made 80 years ago, and that we little by little destroy it because of budgetary issues. We need to reaffirm this promise. And in this promise, if I may say this, it's clear. Access to health is the promise, also to protection when we have a chronic illness. When we see for the different chronic illness remaining payments, we see that it's an issue. Now, it covers 80% of medical care, and this is very high amount. Now, we're not just dismantling the Social Security institution. but that we have different issues in different situations in
Alors, je pense
territories.
qu'on le
We have
détricote
poverty.
en
Well, I think we're
proposant des
dismantling it, but we're
démutualisations, par exemple.
proposing
La question
mutualization, for example.
d'un
This
niveau de
is the
franchise qui deviendrait
question of
insupportable
the
pour les
franchise,
uns et
which
les
will
autres.
be
C'est un
difficult
projet,
for
c'est pas fait. Ça
Voilà,
n'a
non,
each
mais
other. It's a
il y
project.
a-
It's not
donc,
hasn't been
en
done.
effet,
Très insupportable. Pour le coup, est-ce
Is
qu'on
this
ne doit
something
pas
that
avoir
can
une
be borne?
contribution pour que les citoyens
Can
aient
we talk about
conscience
contributions
de
so
leur
that the
appartenance à cette
citizens
collectivité
really
et soient responsables de
feel
l'action
that
de leur
they
projet?
are
Est-ce qu'il ne faut pas
responsible
qu'ils payent un tout petit
for
peu quand même?
their
alors, je
health
pense que,
consumption? They should
alors,
pay
Monsieur Yann-Gaël
something,
le
maybe
disait,
even a little
et
bit.
avant
We have
lui,
heard,
Magali
and
Idéo, on
for
finit
example,
toujours
from
par payer.
Magali and others,
La question,
we
c'est
finished by
est-ce
paying.
qu'on paye
The
de
question
façon
is, do
mutualisée?
we pay
Est-ce
in a
qu'on
mutualized
paye
fashion,
parce qu'on est
or
confronté
do
au
we
risque?
pay
Et je pense
when
que
we're
c'est ça
confronted
le
with
choix
risk?
qui est
I
devant nous
think this is a
aujourd'hui.
choice that
Et
is
dans ce cadre-là,
confronting
il me
us.
semble très
And in
important de
that
réaffirmer la
situation, it's very
dignité de la
important to
cotisation
reaffirm the
sociale.
dignity
La
of social
cotisation,
contribution.
contribution, et
This
notamment la CSG en
contributions are
matière de
important,
santé.
and also
Ensuite,
CSG are
vous me
important.
posez
Now,
la
you
question de
were
la place des
asking the
partenaires sociaux.
question of the
Ma
place of
conviction,
social
c'est que le
partners.
rôle
My
des partenaires
conviction
sociaux,
is
il n'est pas juste
their role
lié au
is
financement.
not
Il est
only
aussi
connected
lié
to
à notre
financing,
capacité
it's
d'être
also
un
related to our
acteur du dialogue
capacity of
social,
being
un acteur de
an
la régulation
actor in the
sociale,
social
et
area
tout
and
particulièrement
regulation in
en ce qui concerne
social
le financement de la
areas,
protection
also
sociale,
and also
un acteur
protection
qui parle du
of
travail.
our citizens. And
Aujourd'hui,
it
on ne
talks
peut pas
about work.
envisager
We cannot
la
envision
hausse des dépenses
today
de santé
the
sans poser la
increasing
question du
health
travail,
expenditures
sans
if we
poser
don't
la question
raise the question
aujourd'hui de
of work.
pourquoi,
Why
quand je regarde les tableaux du
today, when
HCAAM, je
I
suis
look
capable
at
de
the
dire que tel
different
secteur professionnel,
figures,
eh bien,
one
il a une
professional
consommation de
sector
soins plus
has a
importante en matière
higher
de risques
consumption
psychosociaux,
of
en
health,
matière de
different,
TMS.
for
Donc, c'est
example,
quelque chose,
in
c'est un
different
tout. Et la question de la
trauma-related
gouvernance, la
diseases,
question au
etc.
contraire
The question of
d'une gouvernance
governance
qui voit sur le long
is
terme, que
important.
plus
That
que sur un politique
they
qui
should have
regarde
a
quand même
long-term
l'horizon est très court, voire
horizon
aujourd'hui de quelques
rather
semaines,
than just a
pose
short
un problème en
horizon,
matière de
and
choix. Et de
because
ce point de vue,
otherwise the
moi
short term
j'interpelle très
creates
fortement les
problems.
partis politiques qui
Now,
aujourd'hui
also the
sont sur des
political
propositions de
uh,
baisse
arena
des
is
cotisations
in
et
a
des contributions
position
sociales qui sont
to
sur des financements donc de long
really
terme versus
review the
un
long-term
financement comme la
contributions
fiscalisation et tout
rather
particulièrement par la
than with
TVA qui
taxation
est un des
and with the
modèles de financement
VAT,
les plus régressifs qui
which
soient.
is the most
On
regressive
parlera de tout ça,
one.
puisque évidemment il
We'll
y a
be
débat
talking
sur
about
ces
all this
questions.
because we do have a debate
On va terminer le tour
on
de
these
table
issues. We're
introductif.
going to
Franck Vonnet, vous
continue
avez
our
été pendant 4 ans
roundtable.
directeur de la
And
sécurité sociale au
Franck
ministère de
von
l'Action sociale et de la
LENNEP,
Santé.
you're the
Très
President
bien, j'aime bien,
Technical
je
Agency
change
for
régulièrement.
Information and
Vous savez à quel est
Hospitalization.
le nom qu'il faut utiliser.
And you also, in your
Vous avez donc une vision
professional background, you
du
have
système
a vision
global sur
of
son
the global
financement.
system in
Pour
terms of
répondre à
its
la question de la
financing
table ronde,
to answer
l'avenir du
the
financement,
first
Franck, vous le
question,
voyez comment?
which is the future
Alors,
of this
je pense pas
social
mal rebondir
security
sur ce que vient
institution.
de dire
I would
Jocelyne.
like to go
D'abord,
back
vous
on
avez
what we've
dit
heard from
il y a un intérêt à avoir une
Jocelyne.
sécurité
There
sociale et une
is an
protection
interest
sociale
in
qui
having
sont deux
social
choses différentes.
security
Parce qu'on
and
est
social protection.
c'est pas parce
Yes,
que la sécurité
it's not
sociale demain
because
sera
social
remise en cause
security
dans son
tomorrow will be
organisation, dans
actually
son financement, dans ses
reviewing its
institutions, que la sécurité
organization
sociale
and its
dans tous les pays,
financing. Doesn't mean we won't have
il y a des pays sans
social
sécurité
protection.
sociale,
There are
mais il y a
some
quand même
countries
des protection
without
sociale.
social security,
Donc,
but they
et
do have social
effectivement, je l'ai dit, donc il
protection.
peut y avoir des
And I'm
organisations
going to
très différentes. Je
talk
pense qu'il y a
about
toujours
these
une
different
protection
kinds of
sociale devant la
organizations.
crise,
We
les
will
Français
always still
payer
have
les
some
retraites
kind of
et
social protection. We have
projet
retirement,
de prendre en charge la pauvreté,
etc.
ça,
that will
voilà.
continue.
Bismarck et Beveridge quand même.
Mais
So,
oui, il y a ça,
yes,
mais
in
il y a quand même une
fact,
protection sociale. Voilà,
we
donc c'est
do
pour
have
ça,
social
venons là,
protection
la question sur la
regardless
sécurité
of
sociale. Moi,
the
voilà, 80 ans de la vieille
institution.
dame, je les comprends
So
d'abord
this
aussi comme
social
sur le plan
security
institutionnel,
of
la
80
sécurité sociale, avec sa gouvernance, avec ses
institution,
financements.
and
Donc je
we have
commence
to look
là-dessus.
at the
Donc
governance, etc.,
pour dire
etc.
finalement,
Now,
et donc je vais aussi parler un peu de
basically,
financement. On n'a pas beaucoup
and
parlé
I
de
want to talk about
financement
financing. We
depuis
haven't
hier.
spoken enough about that since yes. Well,
Finalement,
it's very important funding.
on a, voilà, vous avez commencé à
We
le dire, on a modifié pas mal
have
depuis 30 ans le
modified
financement de la
already for
sécurité
30
sociale.
years
Aujourd'hui,
the
moins
funding
de
behind the
prélèvements
Social
sur le
Security,
travail et davantage
less
de prélèvements CSG, mais
less
aussi de prélèvements fiscaux. Aujourd'hui, les
less of the
recettes fiscales,
taxation. So the
TVA
fiscal
et autres taxes,
VAT and
c'est
other
30%
taxes is
du financement de la
30%
branche maladie.
of the
C'est plus
financing
que la
of the
CSG.
health
CSG,
sector.
c'est un quart.
It's more than
Alors ça va être
CAG,
moins
which
que les
is one
cotisations, puisqu'il y a quand même les
quarter.
cotisations
It's
patronales
less than
maladie.
the
Il n'y a pas de cotisation salariale, je
patronal
rappelle, puisque c'est de la CSG. Les cotisations
contributions.
patronales maladie, elles, sont
So
encore le premier poste.
they
Mais
still
derrière, c'est le
have the
financement
first
fiscal qui est là.
area. So
Donc
yeah,
TVA et
fiscal
autres taxes.
VAT
Et
and
donc
other
et par
taxes
ailleurs, donc ça
that
c'est la
are
situation actuelle, et on a en
included.
plus un déficit donc,
And we have
de
a
15
deficit budget, some 15 and 20 billion. So do we have this issue to consider? What really I want to say, rather than discussing those, what is the financing and how can we actually do something about the deficit? We already, since last year, we started, and even in more recent, we're saying, well, rather, we should talk about the increasing of what how the purchasing power should be increased. And we can do that either by working on the contributions, or also so less input for your retirements, pensions. We can reduce that. So these are debates that are underway. So what should we do? What are the room for maneuver? What can we reduce? For Social Security, do we need to increase CAG or decrease it? When this is also, it's easier to talk about increasing purchasing power, that it's easier to talk like in that terms. It's not because we talk about it in those terms, doesn't mean that these issues will disappear. Since last year, you have Antoine Fouché, who wrote a book concerning the increasing purchasing power. Everyone is talking about this. And so this is starting to influence and be involved in all the different debates. Those who want to be candidates, for example, take up this topic. And now, how this is a vicious circle that we're talking about. Yes, there are lots of expectations. Yes, nothing is free. So how can we pay the bill at the end? We're looking for income elsewhere, or from the VAT, or others, but it's very complex. Other fiscal taxation is what we'll be looking for. French don't want to pay the franchise. They don't want to have. They want to have more money. That's a priority. To more money for the hospitalization, etc. So everybody wants to have money put into health, but how is it paid for? So we want to have the others that pay. So this is not taking up one's responsibility. The other point, we are abandoning the traditional financing of Social Security, which is looking at the balance between expenditure and the income. We have these, in fact, in the roundtables, we were talking about these things. We talk about this disastrous situation that we're facing in terms of our budgets. So in Social Security, if we abandon it, it would be really a shame. Another consequence, the more we have fiscalization, taxation, the more we'll be raising the question concerning the governance issues, because we're trying to think of the future of Social Security. We have three scenarios. There's a fourth one, which I don't believe there's three major scenarios. The most radical one is that one day, okay, the Social Security no longer works, we should decentralize. And why not put most of the health at the regional level? This is done in other countries. This will not settle the whole problem, but and won't settle the problem of funding, says the moderator. You make a proposal, do something different. It does not respond to all the different questions that one raised. However, that's one scenario. There's countries where they have a regionalized healthcare. That's the first scenario. I don't think it will be in the years to come, but that could happen in the future. Second scenario, less radical, is to say, well, we don't have a balance in our system, so we don't know how to finance, so we don't need Social Security. In many European countries, they do this. This health expenditure is a budgetary expense like other expenses. And so this is not a apocalyptic situation. When I talked to my Bercy friends, they said this would be the good solution. Don't have any Social Security any longer. Of course, so we have another debate, says the moderator. But the third scenario, keep the current governance, and that requires for all of us to say, if we have to get it back in a balance in not a long period, because we heard that we would be in balance in 2029, but we don't have, and to do something about this problem with the 20 billion and to get back to balance is not easy. Today, if we want to defend Social Security, today collectively have to have these efforts. We have the diagnosis, so we have 30 minutes to find a solution. Each one of you, I would like at the end of this roundtable to talk about the key two measures which could respond to what Franck is saying. Would you like to start? Yes. We have 600,000 members. We voted in a Congress. We could increase the CSG. So the purchasing power, and also if we have a retirement problem, it's very clear with us at CFDT, if we would have the CSG, which is increased, it's not easy, but we validate that proposal. However, there are these conditions. We have to have the promise being clear. If the question is the French people, they would never accept to increase the CFG, we would have these health deserts, and so the consentment of financing connected to the effectiveness and transparency of the promise. Today, I think it's not there yet. There's this question also about the management of health care, and so it's not acceptable today. When we had the previous roundtable, we heard this. Each one looks at their private interests for the growth of their professional sector, but that's not acceptable. Maybe it's not acceptable, but from professional point of view, it's acceptable. You have to have governance, which can extract from their private interest areas. So we have to maintain governance, which is a long term, and the question of pluriannuality. When we talk about pluriannualists, we talk about 5 years, and our partners have a longer vision. And we look at the retirement system, for example, in that case, increase the resources, be transparent concerning the efforts required, and to enable governance. Where do you want to go to that extent, as the moderator? The different social partners manage with these different reserves, and they handle this very well, because you can have future situations that arise, so they manage that very well. So, okay, but when you look and concretely, what is the role of social partners in this governance? You have made a parallel here, and against what everyone says, we have to increase CFG, and we have to transform this in the capacity of having reserves. In other words, the question with 208, you had deficits of Social Security. And 2019, we're almost at the balance, and in these different periods of comfort, then we should have some reserves stored. Okay, isn't that a little bit dangerous, says the moderator? I think we need to have reserves also for Social Security, and we should have a cyclical policy. So Social Security today needs to enlarge its coverage, and also there's different social environmental risks as well that need to take into consideration. We've had the different crises in COVID, and if we don't have anticipation and learn these lessons from this, well, so the social partners need to really have this long-term vision. Well, what about their management role? It would be more comfortable that we would be the management in difficult periods as now. Also, it means that this approach will not be possible with this taxation that we've spoken about. So, Philippe, Juvin, how do you react? I would like to applaud this once again. What we've heard, everything is in reciprocity. You cannot handle Social Security if you don't handle other more general topics. If you don't understand, for example, we don't have public money, it comes from a pocket, and it's from your pocket, generally speaking. If we don't handle the financing of retirement, we won't also resolve the balance in general of the budget. Retirement is an important part, is half, basically, of the debt and the debt that is being created. What should we do about that? Well, that's an important question. We need to work longer in this country. We have to stop saying we are the country. We have the high taxes in our country, and the margin for maneuvers are not for the incomes, they're more on the expenditure. Here is for the state and also for all individuals. So we observe there's not just one leak that we have to handle. Everyone's looking for this big leakage and this gap that we can handle. But you asked me 2 measures. It's not possible. We'd have multiple measures that are necessary, and they will have different characteristics, and some of them will be painful. That can have more power to do this. There's a lot of things for the product load, for example, and policy. Yes, it's important to talk about that. So I would say certain things are very well managed because they have clear objectives. I also was thinking, is that different topic is finally we do not make a mistake. We have the PLFSS, but we don't have a good, clear policy for health, and so we need that as well. So, as I'm saying, and I go back about the decentralization issue in a minute, I think this is part of solving the problem. There's not just a miracle recipe, but when you have different high schools that are handled by the state or compared by the regional area, you can see the difference. Of course, our health sector is more complicated than managing a high school. But if it's not complicated, then okay, we wouldn't be here. So decentralization is one of the tools. It won't solve everything, but if we have, for example, different schools, real estate at the territorial level that is handled for schools, for example. And this is an example. At the territorial level, decentralized, they will be handled better than centralization approach. We don't need to have a debate about that. But also the question of the health adjustments required. We have already heard about these, Martin Hirsch. So maybe look how we can better manage. There's not just 2 solutions, there are multiple solutions, and we have to keep in mind that already people have lots of taxation. I'm not opposed to increasing the CFJ because this tax is really represents a large so-called plate, and it's not just the little ones that are important. So, Mr. AMGHAR, you've heard 3 different presentations. Now, are these different views? Is this aligned with your point of view? Well, yeah. We have these different scenarios that you've heard. I want to talk about 2 subjects mentioned, which are not ways of reducing health expenditure, which is our main aim. So, for example, the patient, and we have lots of publications on that topic. The participation of his financing areas will not help with the relevance of funding. It doesn't mean the patient will be renouncing of more expensive treatment. For example, based on their income is taken into consideration and their health state. So certain people will actually reduce their expenditures if they really can feel the cost of health. This can actually lead to different effects. It's too expensive to go to the hospital, so I'm going to take the treatment later. So in other words, be penny-wise economic for the little coins, but really to look at something which this is not an option, where decentralization does not create as such economy in the health area. We have Italians who have a decentralized system. Concretely, it means that the tariffs are not the same. And so you have the rich, wealthier regions, and then poorer regions. We see this in Italy. So this is decentralization is not an answer. Okay, the integrality issue now. Already, I don't know how we plan in investment. We have, for example, real estate plans. We do this. I don't know. You have someone who's paying for the property. Also, I'm making this parallel. We have to look at the mapping of the hospitalization, but how can reconcile all this if we can give power at the right level? I am really impressed. I saw an era when there was a health planning of different establishments and infrastructures, and we have the different roles of who is the payer, the CAAM, the state. This is an element that we have to work on. You have different schemes, but what do we assume to say? We have to look at the hospital mapping. You have deterioration of some hospitals, for example. This is a discourse that has in 2010 that we had this, and we had the movement of the Gilets jaunes, which is one of the consequences of this situation. And so the tax situation is serious, but the health expenditures are really important. So we have the health illness, that we have the expenditures which are more concentrated on chronic illnesses because the cost of treatment is higher, and that is why, structurally speaking, we have these expenditure which is high. This is not the problem. So should we, how can we do economies? There's different levers for this. We should not imagine that the different economies, savings will allow us. In fact, when we're talking about the 16 billion, and now we're going all the way to 35 billion in the future. So this is, so all of this just is half of the effort is done by the savings. So if we have the health cost increasing and we have the increase by the health illness scheme, so the debate is, do we change the organization from the patient to the AMC, or we have a different organization where that we change. So we have arbitration between have an obligatory contribution by, and when we look at 2017, this was not the collapse of communism, but we had what we saw 2 points that were low, but it was lower by 2 points. So all of this is not compatible with the economic situation. We have the increase of health fees, and also Social Security is increasing because of the aging population. We can reduce the current coverage of the healthcare, or we can put things in obligatory. So I would like to ask a question for all of you. I would like to come up with 2 key proposals. Madame, you already made one. And so we have this management of all the expenditures, which is very important. And we have the quantity of work. So we have these social contributions which are not at the right level because of the work situation. Concretely, how in this situation, as of now, so we have a population which is not ready among some of them to have additional taxation. How can we steer all of this? By listening to you, there's different contradictions I'm hearing. So what should we really do? You have already said a proposal, but it's important for us to have a summary which really gives us some concrete avenues for financing. Just to go back on what I was saying, so the CHA increase, we have a part of the population that does not want to have additional deductions. Do we talk about when did we really have the debate to say the model of health coverage and the increasing of the CHA? This is taboo. I think we have to open up this debate and we have to put this on the table that in our French social model, which is based on access to healthcare, are we capable of financing it and paying for it? I think in the case of the different deep aspirations of French people, we can really have this debate, and we need to do it. There is a discouragement on the collective level, and concerning that specific dimension, we have to stop really criticizing the workers being the responsible for the health deficit, saying in France we don't work enough, and so and the workers don't want to hear that. The seniors don't have jobs, and the young people don't either have work. We have to raise the question of work. We want to save our social protection model. We have to also save the possibility of having people work, the younger and the seniors. And this, we have to have the job possibility. So you have these two areas for avenues for improvement. Yes, two as well. Now, the last macro statistics, there's less work that is provided in France as compared to other countries. So this is why we need to create more wealth. And to do that, we have to work more collectively. You're right. When you look at the people, the independents, they work more. But then there's categories of ages that work less. And we have to work on why. The first proposal, we need to be pragmatic. There's tons of proposals we could come up with. What we could do already as of the PLFSS, this is a question, you have different indicators, several indicators, simple ones, which would be visible and transparent. And this would improve the relevance of the system. For example, if you have different injuries, you can find other injuries and how we take care of them. The other proposals, we have to put money where it's scientifically proved to be efficient. Different insurers, mutualizing insurance companies in their package. You have different therapies, things that don't work. I don't want to contribute for things that aren't working. If you you can have an amendment that I'm proposing with PLFSS. We get rid of things that are not efficient. That's a second proposal. I would have lots of others. I think we are in a country which is, we have to understand this clearly. We have a high taxation. We would have people, if they don't have impression, they don't get for their money, then they will refuse the taxation. Education, for example, look at what's happening there. We're telling people, yes, we have a better system. We're specialists. We say that we pretend to have the best soccer team, the best education, the best healthcare. But when we need to measure this, say for the World Cup, okay, the final, that's one thing. There's a point in common with your two argumentations. You need to have a real public debate, social democratic approach on these subjects. But retirement, for example, this is why cannot people understand what's going on with the retirement? Don't, because we did not tell them the whole truth about the retirement situation. Maybe the first step, and that's what you're proposing, Madame, is to have a real democratic debate on these questions. Yes, go ahead, Madame. Yes, concerning retirement, for example, the subject is the question of work and to work better and longer. We can talk about that. But if there is a block and anger about retirement because some persons think they cannot work longer, and the question of the difficulty of their work is an important issue. It's not a technical debate, but it's really we don't want to have a debate about retirement. However, I do see there is a subject for debate. We haven't explained it to very clearly about the subject about retirement. We'll find this kind of also debate about health. Now, the question of retirement. Why what was behind this? The state was giving support, financial support for the retirement. So it's not in balance. With retirement, I believe what we need to do is that all the future civil servants, that they have the future ones, they have to actually make the contributions. You mean collective capitalization is what I call this, obligatory to go for retirements. Once again, we all have the data policy. Once we've had the big debates, it's good, but we all have the data. Now we need the courage to take action. Often we don't give the French people the right data. The health care in France is not the best system in the world. That is a stronger affirmation. We'll be continuing going around your different proposals. I believe, sorry, I'm coming from my financial expertise. We need to put something which is like a golden rule for financing. We have to look at the different conditions. We could imagine if we don't have Social Security, but that wouldn't make much sense. In our current, the gold rule is to have return to balance. For example, at 2027, a plan to get back to balance, and also the CSG is not just to give the protocol. No, the French will not accept that. We want to save our Social Security. We have to make it in balance. And then we also have a voluntary trajectory, and there will be a voluntary trajectory for everyone. We here in the roundtable, we agree, but it's the others. No, it's everyone has to be on the bandwagon. And so there's two options. Either we do what we've done, we talk about it each year when we talk about the PLFSS, but we need to have some more visibility. It's very important to have this visibility, and all the efforts, deficiencies, obligations, they're all important. So there will be obligations for one and the other. We don't just start talking about the reimbursement for the patients, but we could talk about the reimbursement for the professionals. It's a difficult plan. We need lots of efforts from everyone, but it's important for the survival of Social Security. We have to have a captain on board, and this would be the CAAM. And the relationship with the CAAM today is maybe not clear that they can take the leaders, because there are also different political issues. When we start doing what you're saying, then it's not easy to do this. You have the policies, and politics would be coming up with the golden rule, and so CAAM wouldn't be doing that, but it's so setting up this pluriannual plan to get back to balance. This has we have to have continued quality for health activities. We're not just going to go around the table. What I'm saying is we have to have more capacity for the CAAM to go to the hospital and to look at risk management issues, for example. You have already mentioned a lot concerning your visions. You can react to the different positions you've heard here. Well, a lot has been said about the method. We have the pluriannual trajectory. We have to get out of this kind of argumentation. We all have to make efforts, and we have multiple levers, and we all have to activate all this. It will be painful for everyone. We should not hide that. And also different levers, more precise, what we've heard concerning about, for example, evaluation. We look at the different issues. We look at the hospitalization, mapping, etc. We have these different measures which enable us to continue a trajectory until 2030, and then we need to prepare and anticipate for the financial health world of the future. And this is the explosion of people that are overweight. And there's been a twofold increase of overweight amongst young people. This is a health, social drama, and it's also financial problem because this is a lot of expenditure related to this problem of people being overweight. We need to have a health strategy that will be also discussed at the Parliament, which concerns all the citizens. And when we talk about health policy, we were successful for reducing tobacco consumption. For example, there are other levers, thanks to different announcements, different support we propose. For example, to have substitution, for example, for tobacco, cigarettes, food, nutrition campaigns are also important because we can at least reduce this very serious problem of these poor hygiene. Are you optimistic? Yeah, we have the will. Yes, I was European before national. I was in Athens the day when Greece had to sell the port of Pirée. This is historic port. It's like Mont Saint-Michel with the Eiffel Tower and the Versailles Castle. This was a real shock for the Greeks. And we also don't see this disaster coming up if we don't look at this golden rule you're talking about. If we don't seriously look at this, and we'll have a situation that will just fall upon us. We want to be masters of our destiny, but if we continue each year saying, oh, we do a little bit of adjustment here, and we'll kill this big animal, but no, that's not the right approach. And basically, somebody will say, and they will eat this animal. This is just making a parallel. So the social system is something that is very complex, and there will be little steps, little advances, and it will be painful. All the solutions are out on the table. All the different solutions from the auditors, Cour des comptes, etc. All of these are coming and looking at these different solutions. So we're going to let you have words for conclusion. I would like to say a few words in the name of all my colleagues. I would like to applaud the success of this first session of CHAAM by Elizabeth. We can really give her an ovation. A round of applause for Elizabeth for her first CHAAM.